All right. Well, thank you everyone for being here. I'm going to get us started because we have plenty to discuss today. So I'm Sarah Brewer. I'm the director of the education program at Accords. I want to welcome you all for our Accords Education Program seminar. I'll start with what is Accords. Many of you, I think, know, but I see some new names in our attendee list. Accords is supported by the University of Colorado School of Medicine and Children's Hospital Colorado. And it's a unique one-stop shop environment for faculty to conduct pragmatic research, receive various types of services and support for grants and projects, along with incredible mentorship, training, and education in health services research. You can see some of those offerings here on the slide in front of you. I want to point out we recently have added 2 cores and programs to our team here at Accords. So we have a new Learning Health Systems core and a new Pragmatic Trials core. So those are areas of interest for you. Please take a look at the Accords website and check out some of our new offerings. And then I want to highlight that today we have partnered with our shared decision-making program here at Accords to offer this particular series. Jordan, can we advance to our next slide? I want to chat a little bit about our upcoming events before I dive into today. For anyone who's interested in dissemination implementation science, we are offering a workshop, an overview and introduction to dissemination and implementation over the next couple of weeks, so November 9th and 16th. Registration is open on our website. And then over the next couple months, we have a number of speakers. We have Dustin Rovito from Mass General coming to talk about statistical methods. The next in this series on ethics challenges and messy decisions and shared decision-making will be Sarah Tevis on December 6th. And then you'll see we have a couple more in December and January, but mark your calendar for some of these upcoming events. All right. Today we have 3 speakers. Before I introduce them and hand over the floor, just a couple of housekeeping items for our attendees. First, please use our chat or the Q&A function on Zoom to share any questions or comments you have throughout. We'll be monitoring those and incorporating them in our discussion, and we'll have some time for Q&A. Second, as we get closer to the end of our hour together, please look for our evaluation and provide some feedback for us. That helps us to do a good job meeting your needs. Now, today, our seminar is part of the Ethics Challenges and Messy Decisions in Shared Decision-Making series. Today, we're going to talk about ethics and shared decision-making principles and applied examples. And first, we have Dr. Dan Matlock. He's a professor of medicine in the Division of Geriatrics at the University of Colorado School of Medicine. He's board certified in internal medicine, geriatrics, and palliative care, and is currently interim director of Accords. His research is aimed at fundamentally changing and improving how patients make decisions around invasive technologies. He's been funded by NIH, PCORI, and several other foundations. Recently, he's also been named Associate Director of Clinical Innovation for the Denver Veterans Affairs Geriatric Research, Education, and Clinical Center. Second, we'll hear from Laura Scherer, who's received a PhD in social psychology from the Washington University in St. Louis and completed a postdoctoral fellowship at the University of Michigan Center for Bioethics and Social Sciences in Medicine and the Ann Arbor VA. She's an assistant professor at the University of Missouri Department of Psychology before moving in 2018 to pursue a focus on medical decision-making at the University of Colorado. Her research lies at the intersection of behavioral science, decision-making, and medicine, and seeks to understand patient preferences and healthcare seeking versus avoidance, and how to facilitate shared decision-making and improve communication between doctors and patients. Finally, we welcome Dr. Matt Wynia, whose career has included developing a research institute and training programs focusing on bioethics, professionalism, and policy issues. He's led projects on a wide variety of topics related to ethics and professionalism, including understanding and measuring the ethical climate of healthcare organizations and systems, ethics and quality improvement, communication, team-based care, and engaging patients as members of the team. He's on the board of the Health Sciences Policy of the National Academies of Sciences, Engineering, and Medicine, and has served on committees, expert panels, and as a reviewer for the Joint Commission, the Hastings Center, the American Board of Medical Specialties, federal agencies, and other organizations. We have three amazing speakers here with us today, and I will hand the floor to you.
All right, thanks, Sarah. I'm just going to start us off while I'm sharing my slides here and make sure this looks okay. You guys see full screen there?
Yes.
Perfect.
Good. Yeah, if I could pick a couple people to kind of sit down with and debate shared decision making with for an hour, Laura and Matt would be two of the high people on my list because they're really fun to talk to, and they both pushed me and my thinkings around this topic a little bit. They're both philosophically appreciative of the concept of shared decision making, but maybe think about it a little differently. So hopefully we can surface some of that today and just talk about it, because I think there's some interesting challenges here. And so this is a 6 seminar series we've been putting together with Sarah, and this is sort of our kickoff one. And I'll just kind of get right into it. I'm starting off with a little bit of lightness. This is Elaine, for those of you who are Seinfeld fans. This is her at the doctor's office. The doctor was just in the room. He walks out. So she decides to pick up her chart. Back in the day, we used to have paper charts. And she looks at the top, and written, it says difficult patient. And then the doc comes back in. So being Elaine, she confronts him. Why does my chart say difficult patient? And he says, oh, that must be a mistake, and took it and pretended to erase it. And she's like, you can't erase it. It was in pen. And so it's a funny scene, but I like that scene as a light way to talk about something that I think patients are concerned about. And this was another great paper in Health Affairs a little over 10 years ago now, but it was a focus group with patients, or several focus groups with patients, excuse me, asking about why they don't want to question their doctor on things. And there was a lot of just disempowerment in these interviews, and they really did a good job with this focus group, getting people to really share their feelings. And this was one quote that jumped out to me that I like to share. Is the guy going to be pissed at me for not doing what he wanted? Is it going to come out in some other way that's going to lower my quality of life or treatment? Will he do what I want but resent it and therefore not be quite as good, or in some way detrimental to my quality of care? I mean, this was a patient saying why they don't want to question their doc. This is just wrong to me, and I don't want my patients to ever feeling this way. But I think this is a pretty strong theme from talking to patients. And you look at this cover, this BMJ cover was a whole special issue on sort of patient-centered articles. And I remember being excited when I first saw this issue. I was like, wow, look at all the attention it's getting. And then I was at the International Shared Decision Making Conference, and there was a doc who came up and talked about this. And he was actually one of the mentors of the person who guest edited this article, or this whole series. And he said, look at this paper. Look at this iconography. Think of all the suffering that was associated with this kind of iconography in the last century. A revolution is not what patients want. Docs don't want to be at the receiving end of a revolution. Is this really where we want to go? And I really like that perspective, because it's not. Patients don't want to revolt to get their perspectives heard. We really want some sort of much more caring discussion where patients aren't revolting and docs are listening. And but I like to put that up because I think sometimes this conversation gets in that way, and we get to this, which is, what is shared decision making? And it's really, should I just give patients the options and let them choose? And obviously you can see the challenges there, the patients struggling with that approach. There are some definitions. I'm not going to go through all of this, but this is one that I like. The National Quality Forum got together and put out a definition of shared decision making a few years ago. And basically, if you look at the 3 bullets, it says shared decision making should have 3 things: clear, unbiased medical evidence about reasonable alternatives, clinician expertise in communicating, and then this 3rd bullet, patients' values and goals and informed preferences. This is, and I agree with this definition, but I'll tell you, when I present to cardiologists or clinicians that are practicing, or patients in the community, I like this definition. Comes from a book in 1985, A Meeting Between Experts. And I like this just because it's an easy perspective to see that, especially when I talk to docs, you're the expert in the clinical medicine, but they're the expert in them. And if you could see them as an expert in them, and that your job is to bring the shared expertise together to figure out what's right, then I feel like you're getting somewhere and you're sharing a decision. And you're not going so far down like the last slide where you're just giving them options and telling them to decide. This was Timothy Quill, an ethicist at Rochester, wrote an article calling that form of decision making patient abandonment, where you're just abandoning them with the decision. And then the other side is the more familiar model, certainly the model that I saw a lot of when I trained, which is where the doctor knows best and the doctor tells the patient what to do. And honestly, that model that I didn't like when I was part of it is what got me into doing this research and seeing how can we push and nudge this culture in a different direction. So the way we're doing this talk, I'm going to give a couple examples. Laura's going to give a couple examples, and then the head of ethics is going to tell us what's right. Because that's how it's going to go. But I like these two examples. These are the two I work on a lot. But despite being both cardiology examples, they're very different in terms of how they were received, how they were implemented, and some of the challenges we had. And so I'm just going to quickly walk through, 10 years of research for each of them and just highlight a few things, and then hopefully just to stimulate the conversation. But these are two of the decision aids on our website. We have our LVAD decision aid, and then the ICD decision aid. And I'll start with the LVAD, and I'm just going to pause for 1 second and cough. Okay, that's a little better. Sorry about that. All right, so the LVAD tool. Oops, I lost my button. There we go. So thinking about the LVAD, these are two guys that are in our LVAD video. These are the actual patients. We have them signed video release so we can use their images in our work. And you look at these guys on paper, Cliff and Don, and they are almost identical. 60-ish white man, got heart failure at almost the same time, almost the same reasons. Both of them otherwise pretty healthy, maybe a few comorbidities, but not a lot. And Cliff chose to get an LVAD, lived for 8 years, had at least 8 years, had a bunch of complications with it, but has done otherwise extremely well. And then Don chose not to get an LVAD and actually ended up writing a letter to the clinic saying, please stop telling me to get an LVAD. I really don't want one. I used to work for an insurance group and I'm in a small insurance pool. I know if I get an LVAD, then everybody's rates are going to go up. And I just don't want that. And there's other reasons I don't want it. Just let me go to hospice. And I'm very happy with that. And both of them talk about their reasonings in our video, our shared decision-making video. So just for those of you who don't know, a real quick primer on an LVAD. It's basically a little pump that plugs into the ventricle and sucks blood out of the ventricle of the heart and then pumps it into the aorta. So you're basically just giving the heart a boost. You're giving it more output. Downsides is it has to be connected to a wire that's attached to a battery pack that you have to hold on the outside. So you have this permanent hole in your body that's a constant source of infection. You have to carry this 7-pound battery with you, or you have to be plugged in at all times. We've heard some stories of one patient who was out on a boat, couldn't get back quick enough, and it looked like his battery was going to run out, and his wife met him at the dock with the backup batteries, hoping that they would make it in time. So it's a burden to try and have to be plugged in somewhere all the time. This Vice President Cheney had one of these for a couple of years in 2010 before he got his transplant. For a while, these were increasing and they were more common than transplants. It's unfortunately not true, I don't think, today. These have sort of leveled off, and then transplants are going up because of the fentanyl crisis, which is a whole other sad and ethical discussion. But there are just more hearts available these days because of the fentanyl pandemic. But anyway, so we studied this in a 6-site randomized trial funded by PCORI. And we found a really good increase in decision quality. And decision quality is defined by a more informed patient. So our knowledge score went up, making a decision consistent with their values. And so we measured value choice concordance. And we saw increases in both and people who saw our intervention. So that was very exciting to us. That was our primary outcome. And so then we followed that up. Oh, and secondarily, we saw a 26 absolute decreased risk in number of patients choosing to get an LVAD. In our intervention group, only about 55% chose an LVAD. In our control group, 80% chose an LVAD. It kind of gets into one of these questions of like, what is the outcome of shared decision making? Is improving decision quality enough to be a hard outcome? We get this a lot from NIH panels. Like, well, did you improve a clinical outcome? Well, I don't know if we improved any outcome. If we had measured mortality, it could be that our intervention patients don't live as long because they're not choosing LVADs. Is that a good thing or a bad thing? Well, there's an ethical question. But this comes up a lot, is what is the right outcome of shared decision making? But anyway, after the LVAD work and how well that went, we decided to go big, did a follow-up implementation PCORI grant, said, let's implement this at every LVAD program in the country. And so we've been doing that. This is a slide of our adoption at all 175 programs over time. You can see this little black sliver at the top. There were 6 programs that didn't want the decision aid. And what we've heard from people who've declined it is their biggest concern is that volume. They don't want their volume of procedures to go down. So they don't want the shared decision-making video to lower their volume. There's another ethical question embedded there that's maybe one that we've already settled over the years, but it's an interesting one. And then of those sites that have adopted it, 123 say they're currently using it. We've done these little 4-month follow-up surveys to see who's using it. And of those, 80 say they're using it always as standard of care. So this is, even though it's a really niche little area, this is, I think, one of the more successful shared decision-making implementations around. And that we got half the programs in the country to use our little video and tool. So this is one example. Now switching to another example, the defibrillator. This is where I started, in 2007, interviewing docs and patients when I was a research fellow in Ali Kemp's training program here at Accords. And my first K award was around this. And this was the big Medicare trial that was published, or the big trial that was published that convinced Medicare to say, okay, ICDs are something we should pay for. ICDs had been around, but they were usually for that person who had been who'd survived a cardiac arrest, like that person in the airport who got an AED. They've been getting ICDs for a few years. This trial took patients with heart failure who had never had a cardiac arrest and said, let's put this resuscitation device in you, let you walk around with it, and let's see if it helps you live longer. And you can see over 5 years, 60 months, the 29% of people in the intervention arm died compared to 36%. I mean, these are estimates, but 36% in the placebo. And you can ignore the blue line. At the time they started this trial in the late 90s, there was a question of whether an antiarrhythmic would be as good as a defibrillator. An antiarrhythmic in this trial was just as good as placebo. So, but this trial pretty definitively showed that ICDs as prevention save lives. And here's that same data presented as an icon array. I just wanted to show this as an example of the kinds of things we do in shared decision making. It's very much, at least for me, it's very much an applied science. We know from a lot of the work, actually some of the work that Laura's mentors at Michigan have done over the years, that this is a better way to present data. People will be more likely to understand and answer a knowledge question correctly 2 weeks later if you show them data like this. If you ask out of 100 people how many lives would be saved, they'll be more likely to answer that correctly seeing it presented this way, even versus some other ways. And there's been a lot of sort of head-to-head research that has shown that. So, but this is a figure that the kind of figure we'll use in some of our tools to help communicate the risk. But this is the same data from that trial. So Medicare, I was in the midst of starting an R01 to study this, kind of just like we did with the LVAD. And then Medicare came out in 2018 and mandated shared decision-making for defibrillators. This gets into another question of should a payer be involved in mandating this kinds of thing? And that might be something we can talk about. But they kind of say very clearly you have to have a formal shared decision-making encounter, and you have to use an evidence-based decision tool, which they don't really define what they mean by evidence-based. And that's been interpreted 2 ways. Some people say, oh, I'm using a tool that shows evidence, so it's evidence-based. Or I'm using a tool that has been proven to improve decisions, so it's evidence-based. And I've heard both interpretations just from this little language. But anyway, Medicare did it. And I have done similar trials that we did to the LVAD. We're just kind of finishing writing up results, but it's not as good. We had a much harder time implementing. We didn't have the same primary outcome. We didn't achieve it. We didn't get sites to use it as much. 3 of the sites implemented during the pandemic, and we just never got to really get them up to speed to actually implementing it. So even with the law saying they have to do this, we never got them to actually do it. Sorry, somebody is screaming upstairs. I got a little distracted. So anyway, these were these 2 trials, and they're very different. So the last couple slides I'll go through is just sort of compares and contrasts a few things. So there were some big differences in the LVAD. We had a really easy time delivering it. And these are sick patients in the ICU, but they have this LVAD coordinator who helps do education, helps teach the family how to manage it. These LVAD coordinators, we interviewed them before, they hated the industry material. They said, yeah, it looks pretty, but it really feels ugly to give it. They kind of are selling the device. It's the best we have, so we use it. And they were happy to unplug the industry material and plug in a more balanced decision tool almost universally, which was a little bit of a surprise. And it was really easy because people are captive in the ICU. They get a long workup. It was really easy to get a tool in their hands while people are having the discussion. I think another challenge of decision aids is, how do you get this thing in front of somebody when they're actually in their head weighing the pros and cons? In the LVAD space, we kind of knew when they were doing that. We knew when they were offered. It was easy. So we had really pretty easy uptake. And then I go to the ICD. There, we're trying to do it in an outpatient clinic with patients who aren't as sick, with busy electrophysiologists telling them they need to deliver this. Our goal was also to get the tool in their hands before, but we couldn't always even identify who on their schedule was coming for an ICD conversation, because sometimes these are referred from outside clinics and you don't even know why they're coming. And so we had a real hard time even with patient identification. So what ended up happening in that trial is a lot of the electrophysiologists would give it to them and say, take this home and look at it, so they could check the box for the mandate, because legally they had to do something. But I'm not sure it really improved the discussion the way I think it did with the LVADs. The other thing that's different is in the LVAD, physicians saw a need for it, despite having one of the biggest survival benefits of any therapy I've seen and ever published in the New England Journal. It goes from like 20% survival to 80% survival at a year. I mean, a huge benefit if you get an LVAD. Clinicians said, I want to do shared decision making here. We interviewed one of the highest volume surgeons in the country, and he said, I never want to do an LVAD in somebody who doesn't know where they're getting into, because I've seen it go well and I've seen it go poorly. And so something about the LVAD being major enough really made the docs feel like this is something they could do. Whereas the ICDs were like, hey, this is preventive medicine. We're going to prevent sudden death. This should be a quality measure. I've seen that written a couple of times. We should measure quality for the rate of ICDs that are put in somebody. So, you know, and these are kind of summarizing some of the big differences, but it's interesting. Even with a legal mandate, we're having a much harder time with the defibrillators. Whereas without a legal mandate, something about the LVAD space felt like a place for shared decisions. So some questions, you know, should all decisions be shared decisions? Maybe some of those defibrillator patients really aren't at equipoise. Laura's going to bring up some better examples, so I'll leave that for her. Is the goal of shared decision making to change decisions? You know, what is the right outcome? I certainly have my opinion, but I think that's not an opinion that's shared by everybody. And should Medicare and other payers be getting involved? So I'll hand that over to Laura. I always like to end with something in the desert Southwest, because I think it's a nice analogy for culture change, which I think is what we do in our program. If you take sandstone and just keep dumping water on it over millions of years, you just get these amazingly beautiful places. So with that, I'll stop share. Laura, I'll let you take over.
Unmute myself. There we go. And can you all see that?
We see your full PowerPoint window. There you go.
Yep, got it. Okay, so I'm going to build a little bit on Dan's first question, which is, should all decisions be shared decisions, by asking a question: when or under what circumstances should clinicians engage in shared decision making? All the time? Only some of the time? If only some of the time, when? And I'm going to go through 3 really brief examples to illustrate when this question came up in our research. So these 3 on-the-ground examples that I'm going to be going through are drawing from an evaluation of a shared decision-making clinician training program that we did over the course of the last 4 years. I'll tell you a little bit more about that in a second. And that evaluation of the training program raised questions about what is clinical equipoise, and is this a good moment to be doing shared decision-making according to clinicians who are practicing clinicians out in the state of Colorado. Is COVID-19 vaccination a good place for shared decision-making? Also came up in that same evaluation project. And then I'm going to pivot a little bit to a completely different context, which is breast cancer screening for women age 40 to 49. And I'll give you the context for that in just a second. So the SHARE approach is a clinician training program, a curriculum that was developed by the Agency for Healthcare Research and Quality way back in 2014. And for the past 4 years or so, we have been involved in a project to update and also evaluate the effectiveness of this training curriculum. It teaches clinicians 5 essential elements of shared decision-making that are part of the SHARE acronym here that you can see. So seek your patient's participation, help them to explore different options, assess their values and preferences, reach a decision, and then evaluate their decision. So I'm just giving you that background so that you kind of understand what this program is in the broadest possible sense. So the other thing about the SHARE approach training curriculum is that it teaches a pretty broad and general approach to shared decision-making. So Dan gave you a couple of really good examples of shared decision-making using a decision aid for a discrete decision. Whereas this SHARE curriculum from ARC teaches clinicians just how to talk shared decision-making on a daily basis with their patients. And the way in which ARC has conceptualized moments for decision-making, and that we kept in this curriculum when we were evaluating it, is that shared decision-making can happen when there are multiple options for treatment, and perhaps we don't know what's best. So this is the traditional sense of clinical equipoise, wherein, it forms the ethical basis for doing clinical trials, for example. So when we don't know what's best and there are multiple options, we engage in shared decision-making. There are also cases where we do know a lot about the treatment options, but there's this balance of benefits and harms that different people might weigh differently. And so that's another moment for shared decision-making, because reasonable people might look at the evidence and say, I want to do A, or I want to do B, or perhaps I don't want to do either of these things. And so those are moments where the clinician can help guide the patient through this decision process. And then the third moment for shared decision-making according to ARC and the SHARE approach curriculum is when complex problem solving is needed. So maybe there is one particular treatment option that is best and is recommended, but this particular patient has complicated life circumstances or comorbidities that make it hard to implement that particular treatment regimen. And so sort of the complete picture has to be worked through with that patient in order to come to a plan that's best for them and that fits their life and their preferences and their needs. So those are the 3 moments that this training curriculum says that shared decision-making should occur. And I'm going to focus next on those first 2. So when there are multiple options, we don't know what's best, and when reasonable people might disagree about what's best for them, given being informed of the benefits and harms. So we implemented this training curriculum in 12 practices located across Colorado. And this map just gives you a general sense of where we were doing this research. And these were 10 primary care practices and 2 cardiology practices where we implemented SHARE. And as a part of the implementation, we trained everyone at the practice. We got feedback on the training. We evaluated shared decision-making that was happening in clinical encounters. And we also had what we called learning calls. So members of the practice, in particular the practice leads, could get on a phone call with each other and discuss shared decision-making and what kinds of challenges and questions they had about it. And of course, we as the project coordinators would be there. So me and Dan were both there. I was the PI of this project. And one of the things that we noticed through these learning calls is that even after the training, clinicians were pretty unfamiliar with the notion of clinical equipoise. And they didn't quite understand that as a moment for shared decision-making. One of the reasons why was represented by this quote from one of our participants. And he said, I never have equipoise. If that's what I'm supposed to be doing shared decision-making, I'll never do it. Essentially what he was saying here is, I always have an opinion about what's best for my patient, and I'm going to share that opinion. And so if you're telling me that I have to be at complete equipoise and I really have to not know, then I'm not going to recognize the moments for shared decision-making. As a result, I'm not going to do it. And so here's my question, particularly targeted at Matt. So under what circumstances should clinicians maybe express equipoise and engage in shared decision-making, even if they don't feel it on the inside? So should we think about shared decision-making moments as moments of behavioral equipoise? I am acting as though there are these equal choices, but perhaps I have an opinion that I'll only share if the patient asks, and they do often ask. And then the second question I have is it reasonable to work to change this mindset of never having equipoise and to help to, as a part of this training curriculum, for example, help to expand clinicians' mindsets about when they might be a little bit more equal in terms of what they see as the best option forward. So those are my two questions for you, Matt. I have more though. So we had another insight from implementing Scherer. And that comes from the fact that we implemented Scherer during the COVID-19 pandemic. So we started to roll out this training and practices right as the vaccine became available and practices started opening up for in-person encounters again. And one of the common requests that we got from these practices is, can you please give us a COVID-19 vaccine decision aid? Because we are hoping that by giving people information about the benefits and harms of the COVID-19 vaccine, that it'll become obvious to our patients that the benefits outweigh the harms, and then they're going to want to get vaccinated. So this, from one perspective, is very outside the scope of shared decision-making, because it is giving people information for the purpose of trying to persuade them to do something that you definitely want them to do. On the other hand, you can approach this situation with shared decision-making techniques and perhaps take a very open approach to the possibility that you have no control over whether the person accepts the vaccine. And so you are just trying to give them the best possible information in order to facilitate them making a choice. And that's completely consistent with this idea that clinicians rarely have equipoise, but you can do shared decision-making even in the absence of true underlying equipoise. And so, but then shared decision-making is not supposed to be persuasive. We're supposed to be open to the possibility that people may make one choice or another. And so my question for Matt is whether COVID-19 vaccination is an appropriate place for shared decision-making, and why or why not. Now I want to get to my third example, on the ground example, and this is a topic pivot, getting to mammograms for women in their 40s. So I have an R01 grant that is focused on shared decision-making for women in their 40s to decide when to start having regular mammograms. And the premise of shared decision-making in that age range is that the United States Preventive Services Task Force has, for the last 14 years, recommended that people in this age range make a decision with their doctor about when to start having mammograms. But as many of you are probably already aware, just this year, the USPSTF said, actually, we think all women should start having screening at age 40, and they should screen every other year. So it kind of messed up parts of our study. It wasn't, a fatal wound to it, but it definitely posed a challenge. But one of the things that is really interesting about the state of affairs is that although the USPSTF says everyone should start screening every other year starting at age 40, they also write that shared decision-making is a core value and should happen at all levels of their recommendation. So the presumption here is that even though everyone should start screening at 40, shared decision-making should also be happening for everybody. And so my question to Matt is whether there truly is an ethical imperative here to inform women about the benefits and harms of mammograms. The USPSTF says this is a core value and stop short of calling it an ethical imperative, but they strongly imply it. They're also saying everybody should start screening at 40. Do we take the time? Do we spend the money to communicate the benefits and harms, even though that might dissuade some people from following the new USPSTF guideline? And that's all I have. So at this point, I am going to stop sharing. And now Matt hopefully can answer all of my questions.
Thank you. This is going to be fun. So I don't have slides. I do have thoughts, and maybe I'll start with Laura's questions and sort of move backwards towards Dan's, which I think of as sort of almost bigger picture, although honestly, Laura's questions are pretty big picture also. I was intrigued when I first saw this sort of notion of clinical equipoise. Because most of us, in the bioethics arena, most of us in clinical work, actually, because like during medical school or during training, you get responsible conduct of research training. That term, equipoise, is from the research ethics arena, right? Which means squeezing it into the clinical environment is going to be a little awkward to begin with. In research, we don't know the best approach yet. We have to warn patients they might not get benefit directly from the thing that they are doing. They might be doing this entirely to help the community to learn more. We in fact take pains to tell people we can't advise them on whether to enroll in the research project or not, because we don't know if it's a good idea or not, because we as a scientific community don't know whether this thing works yet or not. I will say, by the way, it is important to notice the definition, which was not I don't know the right thing to do here. It's we don't know the right thing to do here. And that comes up in research as well. There are plenty of researchers who do studies and believe a priori that they have a pretty good sense that this thing is going to be valuable. They may even really be hoping that it's valuable. And so, we do things like separating the informed consent process for research so that it's not carried out by the patient's clinician. And the reason for that is to avoid the possibility of the research participant picking up on the hope of their doctor that this might work for them and starting to think that this is clinical care and not research. It's called a therapeutic misconception. Right. So it's really common for informed consent in research to not be in the hands of your doctor. It's given to someone else because we're trying to avoid this. That's quite different from clinical care. In clinical care, we are trying to do the best thing for the patient. We are putting ourselves in their shoes, thinking, what would be the best thing for you? We very often think we know the right thing to do. And by the way, patients in the clinical environment are coming to us for advice and guidance, right? They want our advice. That's why they're there. So the differences between using that term equipoise in the research arena and using it in the clinical arena, I think those are quite different. And on top of all that, that is a term that's just very easy to misunderstand. Equipoise, I just mentioned, is really a state of the profession. It's not a state that any one of us needs to be in as an individual ever. And in the clinical environment, certainly, I'm on board with the guy in your study who said, I'm never in complete equipoise. I always have some kind of an opinion. And by the way, if I have that opinion, I think the patient would like to hear that opinion. They're paying to come see me to get my opinion. So I think, if we as a professional community are really in equipoise about whether treatment A or treatment B is better, we should do research on it. And when we do that research, we do the research so that we can get out of equipoise. And once we're out of equipoise, it's not research anymore. Now it's clinical practice. We can recommend it. So we can make recommendations in clinical practice. Just because we can recommend something doesn't mean we don't have to obtain informed consent. And informed consent is step one of the 3-step version of SDM, of the definition of shared decision making that Dan put up in one of his early slides. If you were to go back and reread those, you'll notice step one is the definition of informed consent. The next steps are also, it's important to know where the patient is coming from. They too are an expert in what's most important to them, what their values are. Even if you have a very strong sense of what your recommendation is, they might reject your recommendation. And you need to find that out before you press it upon them, right? So shared decision-making is basically informed consent plus. It's a more robust, more respectful version of old-fashioned informed consent. And my sense is we use SDM, shared decision-making, anytime that there are legitimate options available. Even if you think one of the options is best, and that's what you would definitely recommend, I think you are obliged, in fact, often to say that to the patient, to tell them what you would recommend, because they came to you for that advice. Shared decision-making means, though, stepping back and saying, okay, that's what I recommend, but what's important to you? Because honestly, there are other people who might choose differently. I've had patients who did not take my advice. And if possible, shared decision-making means me telling you about one of those patients who didn't take my advice and why, right? So that it's real to you, that you can make a different decision. The second question, so that's about the term clinical equipoise. I think the second question you asked about was COVID-19 vaccination. And the challenge with this one is that I don't think this poses the same kind of dilemmas that some of the others do, which are really about, sort of how paternalistic, how much should we press our recommendations on people, because we're pressing the recommendation here less because we think we know what's best for that patient, and more because vaccination is how we protect others. And as long as that was true with COVID-19, which in the early studies looking at the COVID-19 vaccine suggested it was quite protective in terms of preventing spread of the illness, it is less so today, which is one of the reasons why many organizations have backed off of their COVID-19 mandates. Because if the only person you're endangering is yourself, that's a shared decision-making thing. If you're talking about endangering other people, that's when it becomes more than just a recommendation. Sometimes it even becomes a mandate. So, we don't do shared decision-making on whether to enforce speed limits or red light laws, right? I mean, we do tons of things. We don't do shared decision-making with restaurants or whether they have to live up to cleanliness standards, right? These are all things that impinge on the right of that person or that organization to do what they want to do, but it's impinging on that right in order to protect the larger community. So in some ways, I think that takes it out of the shared decision-making realm. Once it goes back, once it becomes something considerably stronger than just a recommendation. And that gets to the breast cancer screening, I guess, because to my mind, breast cancer screening is a perfect place for shared decision-making. There are definitely clinicians who are completely on board with this, biannual screening or biennial screening for breast cancer among women 40 to 50. But as you just pointed out, recommendations on that have changed over time. They could change again. It's not like that was 100% slam dunk. And as the task force pointed out, those are recommendations. They're not mandates. They're recommendations. So, and the difference here, not getting screened for breast cancer does not put you at risk of hurting a bunch of other people. This is a very personal decision. It's readily apparent to me that different people place different values on the risks and benefits of screening in that age range. It's like prostate cancer screening or hip replacement or LVADs, many places where, to me, it's really obvious shared decision-making is the right way to go. So now that leads me to Dan's points or questions about, so what decisions do not require shared decision-making? Sorry, was someone trying to say something?
Matt, maybe we pause for a second. Laura raised her hand a couple times, and then there's a little bit of discussion that should happen before we move to Dan's
okay.
ethical dilemma questions.
I think one of the things that I wanted to ask you is that as you were talking, one of the thing that stood out to me is you said legitimate options. And then you went on to say, so, you know, we have had COVID-19 vaccine mandates. Now you don't have legitimate options. There's one option. You need to do this, for example, in order to stay employed by a particular organization. But in the absence of mandates, who is to judge whether there are legitimate options?
I think if you can imagine, so first of all, of course, you know, the clinician ends up kind of making this judgment about whether, you know, your recommendation is more than just a recommendation. It is a command, right? And there are doctors who do that. I don't think it's the wise way to go, but I've definitely known clinicians who, you know, the famous maybe or infamous example of this is around pediatric vaccinations, where there have been pediatricians who say, look, if you won't get your kids vaccinated, they can't come to this clinic. I think that's unwise. I wouldn't do that myself. But that is a clinician basically saying, this isn't just a recommendation anymore. To me, this is a mandate. There is no other choice. I think those are often around, you know, where I feel like you might be putting other patients in my waiting room at risk, right? So you can risk your own health, but you can't risk everyone else's health, and I won't facilitate or endorse that. That's the argument that's often made. When it is your own health, I mean, you can make a pretty strong case that every decision in healthcare is a preference-sensitive decision, in the sense that, with very few exceptions, if a patient says, I don't want to do that, you cannot force them to do it. That means it's a preference-sensitive decision. You may not agree with it, right? But it's legitimate for them to make a decision other than what you recommended.
So then I have one that really helps. And I have one follow-up question. This is relevant to breast cancer screening. So it takes time to discuss the benefits and harms of breast cancer screening, and overdiagnosis is a notoriously difficult thing to explain to people. It's very counterintuitive.
Yeah.
And so is there, given that this, you said this is a good place for shared decision-making, is there an ethical obligation on the part of the clinician to go through those benefits and harms before providing screening?
So I like to think there probably is, and I do talk about those things with patients. But maybe that's because I am, you know, less on board with the 100% every single person ought to get screening starting at age 40. I've seen overdiagnosis, and right, so having some experiences like that, where people are really harmed by, you know, something that really should not have harmed them, has made me maybe more reticent in that particular environment. I have the same point of view on prostate cancer screening, by the way. So maybe that's just me, but I think of this as being a really relevant place for shared decision making, because I think it is completely legitimate for some women to say, yeah, I want to do that, and others to say, I don't think so, not for me. Maybe I'll move to my thoughts about Dan's presentation, because they actually build a little on this. His first question was, are there some decisions that do not require shared decision making? And that is related to the point I just made, which is there are people, Dan may even be one of them, who believe that literally every decision we make in healthcare probably could benefit from better shared decision making. That there are no decisions where it would be illegitimate for, with the possible exception of decisions that put others at risk. But you know, Dan might agree that that there are no decisions where it's a slam dunk and should be required, and you shouldn't talk about, you know, the possibility of someone saying, no, I don't want that. So I'll give you 4 where I think these are relatively common type decisions that do not at least always require shared decision making. One is the classic exception to informed consent, which is emergencies. right? So there is a well-recognized exception to the requirement that you obtain informed consent if someone is in extremis and they cannot participate in shared decision-making, you can't get a hold of their proxy, you do what you can to keep them alive and to bring them back so that they can start participating in decisions. So that's an obvious one. The next one is what I would call trivial decisions. But recognizing that what's my trivial decision might not be your trivial decision. I'll just say, I'm on the inpatient service right now. We make a dozen decisions on every patient we see. They are decisions like, should we check a CBC again in 6 hours or 12 hours or tomorrow? Do you want to add, a BUN and creatinine to the labs from this morning? Do you think Cipro or amoxicillin for going home? Right? These things are not decisions that we go back and sit down with the patient and say, what do you think? Should we check your CBC in 6 hours, or would you prefer doing it tomorrow morning? Unless the patient specifically says, man, could you please stop drawing my blood so often? We just make those decisions and move on. And I don't, it's kind of a risk benefit or a cost benefit assessment of, do you really need to check everything with the patient in terms of all these tiny decisions that get made all the time, especially in an inpatient environment. The third
Matt, there's
one,
a really interesting question. Oh, sorry. There's a
Yeah.
really interesting question that just came through the chat. Is there an ethical dilemma if the provider does not talk to a patient about medical aid in dying as an option because they personally don't feel it's morally correct?
So that's going to be so I have four. I'll do number 3 first, and then I'll get to that
Okay.
one.
Okay.
So number 3 is the one we've already talked about, so I'll do that fast. It's a decision where the answer is both obvious and it affects the well-being of others. So vaccinations. These are not just recommendations anymore. They often are mandates. There's a big gray space between a recommendation and a mandate. And within that gray space, we push harder to get people to do what it is that we think they ought to do. And we push harder and harder the more the decision doesn't just affect them and might affect others. And then number 4, I'm so glad that this was brought up. I will put these sort of morally contentious decisions into a bucket where there are questions about whether it is ever or sometimes or never okay for clinicians to raise the decision to begin with. And instead, they should wait and only even discuss the options if it's raised by the patient. And abortion, medical aid in dying are the obvious examples here, right? It's very difficult to imagine someone making the argument that, gosh, every pregnant patient who comes in, you should say, okay, let's talk about your decisions here, right? Similarly, every patient with a life-limiting illness, do you really think doctors ought to sit down and say, okay, here are the options. You could do chemotherapy or you could kill yourself. What do you think? Right? That is, no one's going to recommend that. Should not happen. And yet, there are arguments being raised about whether in some circumstances, especially if you think the patient, who's nearing the end of their life and does not maybe know about the option of medical aid in dying, whether there is an ethical obligation to raise that. There was a powerful argument, a very powerful piece about this. I'm pretty sure it was in the Canadian Medical Association Journal about a patient who it became clear that the patient did not know that assisted dying was available to them if they wanted it, and they shot themselves in their bathtub. And incredibly traumatic for the entire family, of course, and for the doctor who really started to question their own decision to have never brought it up and to have said, I'm here for you if you want to talk about other options. And then there's the question of, okay, so what if the patient does bring this up? Is that then a good place for shared decision making? And I think there, yes, absolutely. Once the patient is contemplating, whether to have an abortion, whether to carry out medical aid and dying, these are highly contentious issues. Clearly, some people think they're a good idea and other people think they're a terrible idea. So they're right in the sweet spot in some ways for where a shared decision-making conversation really makes sense for that. Dan had two more questions that I can, I think, address, not to say answer, but I'll give you my opinion on them. What is the goal of shared decision-making? Is it to change the decision? Well, the goal of shared decision-making is better decisions. I think you put up a chart that sort of shows the goal of shared decision-making. It's for the decision that the patient is making to be concordant with what they really want. So unless we are getting it right all the time right now, shared decision-making will change some people's decisions. If shared decision-making does not change anyone's decision, then you shouldn't do it. It's a waste of time because it's not changing anyone's decision. So that's kind of a hedge between those. But I think, if no one, after going through the shared decision-making process, makes a different, better decision than they would have otherwise, then I would probably at least focus my efforts and my time on shared decision-making for decisions where we think maybe people are making decisions that are not concordant with their actual preferences. And should we get payers involved? Payers have an obvious conflict of interest in this space, so I do not love getting payers involved. But I will say, if we fail to change our culture and adopt a shared decision-making approach, they are going to start forcing the issue because we have already proven over time that informed consent becomes a rote process that does not change anyone's decision hardly ever, and which can easily be turned to our personal and professional benefit. So I think the payers are going to get involved if we fail to pick up shared decision-making tools and use them. That's my my opinions. I won't call them answers.
Those are great opinions. It actually gave me some language that I might actually put into some grants I'm writing. I really like the way you talk about a lot of this stuff, Matt. I really do. I always like hearing you talk about this. There's a follow-up comment in one of the things about, but what if the patient wants to talk about it and the doctor won't go there with them and keeps pushing hospice? I think this is about the medical aid and dying. I mean, I think, Matt, I'm curious what you say, but there's sort of if you don't want to provide something that is sort of available to people, then I kind of feel like as clinicians, you're not ethically obligated to do it, but you're sort of ethically obligated to at least help that patient find somebody who is. I don't know. Like, if I'm not comfortable prescribing it, but a patient really wants it, then I should probably say, well, let me see if one of my colleagues is comfortable with this. I think that's a tough situation.
It is, and I think the challenge there is you start thinking about other examples, right? So abortion and aid and dying are the obvious examples, but what about the patient who really wants opiates?
Mm-hmm.
And I'm not willing to prescribe them to you.
Yeah.
Am I obligated to say, I do know a pill mill down the road?
Yeah.
I want to thank all of you. We are right at time. But this is a wonderful discussion. Thank you, especially Matt, for answering some tough questions and providing some insights and frameworks for people to grapple with these big issues. And for those attendees who are still on, the evaluation link is in the chat, and we would love to hear your feedback and input as well. Thank you, everyone, and have a great afternoon.
Thank you.
Thanks, everybody.
Take care, guys.
See you guys.
Bye.